This video will be continuing with our terms to know slides, and this video will be covering uh, the spine conditions of scoliosis, pectus excavatum, and pectus carinatum. So these bottom three right there. So scoliosis, this is probably one you've heard about and you're familiar with, at least I assume so. Scoliosis simply means an abnormal curvature of the spine. In the very first video, which was the review of the anatomy, I gave you a short look at the proper posture and what the spine should look like. So a scoliosis is going to be a deviation of that spine. There's lots of types of this deviation. The one that you're looking at here is a double major. This is a very common scoliosis that occurs, but you can also see this one is a very significant scoliosis. So the most common type of scoliosis throughout the world and for sure in the United States is this idiopathic. Remember, idiopathic just means we don't exactly know why or how it starts, but it just does. It just appears. So you can see here on this individual a nice curvature of that spine, even without being able to look directly at those bones. But you can see that nice curvature of the spine. Occurs in 500,000 adolescents in the United States every year. And then they've got it broken down as infantile scoliosis, a juvenile, or an adolescent scoliosis, depending on the age at which it's identified. So primary cause of that scoliosis, again, is idiopathic. The most common demographics of people that scoliosis affects is in young women, 12 to 16. And that's the time, I don't know if they still do this, but that's the time that I was checked myself for scoliosis when I was in middle school, probably, I don't know, 8th grade-ish. I don't know exactly how old I was in 8th grade, but it was probably 7th, 8th, 9th grade, somewhere right in there where I was tested for scoliosis, and I'm not sure if they still do that or not. So you may or may not have been tested for scoliosis at your school. This is some of those curvatures that we might see with our scoliosis. So you can have simply a unilateral curve to one side, either in the thoracic vertebral region or in the lumbar region. It could span both regions, the thoracolumbar curve, or you could have this double major, which in my experience is the more common of the two, where you're going to have a curve and then a correcting curve on the way back up. So another consideration to take into account, I know, for example, we were just looking at the vertebrae here, but just realize if you have a curve up in the thoracic vertebrae, you're also going to impact your ribs, right? So we're going to develop a concave side and a convex side. The spinous process is going to deviate to that concave side. So we'll come back up here and look. So we're going to have a concave side and a convex side. That's what we're kind of looking at here. So you're going to have that develop in the ribs as well. You can see here that on the convex side, those ribs, if you think three-dimensionally, those ribs are going to be closer together on this excuse me, I misspoke. Let me come look at this image again. On the convex side, the ribs are going to be more spaced out. So you can see that in this image here. The ribs are going to space out on the convex side, and on the concave side, you're going to have a squishing effect. So you're going to have less volume for the ribs on that concave side, and you can see that there. So let's come back to this image here. So on the concave side, the ribs are closer together. That is correct. On the concave side, the ribs are closer. On the convex side, the ribs will have more space because you're creating a convexity. I've mentioned this Cobb angle in a different video. I'm failing to remember what it was specifically we were talking about. However, we're going to have this same Cobb angle in scoliosis where you identify where the curvature really begins. You're going to be able to draw those lines, and then you're going to create an angle, which is you are then going to use to determine the gravity of the scoliosis or how severe it is. This is a little bit more on the scoliosis. You could have it be congenital, right, where it runs in your family. This is going to be less common. I wanted to get back to, so here's some symptoms and manifestations of that scoliosis. So if you think about what's happening, right, we're having a deviation of the spine and potentially the ribs if if it's happening superior enough. You're having deviations of the spine, so that's obviously going to affect some muscles. You're obviously going to affecting the nervous system. You're potentially going to have some, uh, well, you're for sure going to have some malalignment, right? Some, what's the word I'm looking for? It's going to be different on each side, right? You're not going to be symmetrical. So there it is. You're asymmetrical on both sides of your body. So when we look at these symptoms, a lot of this is going to be coming because you have tight muscles or you have weak muscles on a side. Maybe your nervous system isn't being affected equally on each side. So hence, maybe we're going to be developing headaches. On one side, on the concave side, maybe your muscles are really stretched out, especially your trapezius, as it goes up and attaches at that external occipital protuberance. Digestive problems, maybe you're getting squished, right? Maybe your intestines are getting squished on one side. This one was interesting to me. Menstrual cycle disturbances. Remember, idiopathic scoliosis is most common in our young females. This is kind of interesting. I don't really have a thought outside of that this is a common symptom, I guess, for those young women that develop scoliosis. Leg, hip, and knee pain. Again, just think about what's happening, right? You're creating imbalance in the body. So maybe your growth will be changed because of that. Head not centered above the pelvis, leaning of the body. I also want you to think really quickly, scoliosis, we're going to have some severe examples here in this slideshow. But I want you to realize that there's a lot more instances of less severe scoliosis. And scoliosis can go undiagnosed for quite a long period of time, especially think in our young females, right? They have we already have such problems with body image here in America and in the world in general, but I would especially say in America. We've already got so many body image issues that are already occurring, and now you have a young female that develops a scoliosis, right? And the lengths that we all go to hide our bodily malformations, right? So you may realize that some of this scoliosis, we have all these signs and symptoms, but maybe it's going underdiagnosed because people are going to lengths to hide their scoliosis, especially at a young age, right? Wearing baggy sweatshirts or baggy shirts, wearing backpacks constantly or things on their back so that you can't look at that, right? They're going to try to hold their head erect. So even though we have all these, we're going to see that we have many instances of less severe cases where the signs and symptoms aren't going to be as severe and it can go undiagnosed. So realize that scoliosis can develop and progress, right? It's not something that you're born with and it stays at that exact cob angle, right? It's something that can progress and develop over time. So we have some early and some advanced stages. Depending on how bad the scoliosis becomes is going to determine where you're at, whether early or advanced. Going to keep going here. So screening for this. As I already mentioned, I was screened in middle school for myself. Adams forward bend test. I remember lining up in my entire grade during gym classes when we did it. All we did was you walk in. They had 8 people standing there. You took your shirt off. They told you to bend over to about 90 degrees. And then what they were looking for, see if we can see here, what they were looking for actually is a rib malformations, or they're looking to just see if the spine is running straight up and down. I can't recall exactly, but I think my examiner actually just ran their fingers up and down my vertebrae. I've done this with many of my athletes, where you just run your fingers and you're generally assessing if that spine is straight. You're looking to see if you have any asymmetry between the ribs. So if someone is identified to have a positive Adams forward bend test, then they're going to be sent over to a physician where they can take an x-ray. Maybe they can do that cob angle and they can figure out what they're looking at here with that scoliosis and begin to monitor it going forward. This is another example of that Adams forward bend test. You can also see without that Adams forward bend test, this is a severe enough case. You can just look and say, yeah, that is for sure a scoliosis. You can see here just the unilateral bend. It's obviously up into that thoracic vertebrae because we see the different rib formations there. So now I want you to think grade 1, grade 2, grade 3, right? Obviously, the more severe the Cobb angle, the higher the grade is going to be. So we've got several different treatment options. Obviously, we're going to have physical therapy. We're going to have our rehab. We're going to have our exercises, our exercise. We can have other things that help us, making sure the person is getting correct bone nutrients, et cetera, et cetera. They also have some braces, and I think we have some pictures. Yep, we've got some nice pictures of these braces that we can use. The goal of the braces is not to entirely correct the scoliosis, but it's to help limit the amount of curvature that will develop, especially in these growing individuals. You can imagine, as a young person, how excited you would be to wear a brace of this magnitude. I actually remember a girl growing up that I went to school with. She had some back problems and would wear this brace. And, now that I'm a little older, I think I can appreciate her courage in just going to school with her back braces on every day, and just realizing that it is what it was, and she was thinking more long term about herself and her health, and that's kind of a cool memory that I have for her. So we'll keep going down here. This is some of those goals and success of the bracing. Remember, really stopping the progression of that scoliosis. Realize, I don't know if it says it here. If you have a curvature of really less than here, I just saw it. Now, there we go. If you have a curvature of less than 50 degrees, oftentimes people are able to live with that okay, with minimal discomfort. I mean, obviously, it's going to be dependent on the person. So if you can utilize a brace and really limit that curvature down to a 20 or a 30-degree Cobb angle, I think that would be considered a successful bracing. And once you stop growing, the chances of that spine moving decrease. It still can happen, but it decreases. So qualifications for surgery. Preteens or teens with a curve in magnitude of about 50 degrees. So realize that's going to be highly dependent, right? If a person's at 45 degrees and they are experiencing all sorts of discomfort and problems and pain, and they're having breathing problems, right? And they're having bowel problems and other things, obviously that person might be more of a candidate for surgery as someone else that has a 55 or 60 degree curvature, but they're able to really live their life fairly comfortably and they don't experience many problems. So as with all things, it really is dependent on the symptoms for an individual for surgery here. I want to keep going. I'm going to just cruise through this. So this is some examples of this. I just want to highlight this right here. Only 10% of adolescents with curves greater than 10 degrees require active treatment. Of these, 85 to 90% can be treated with non-surgical methods. So that kind of gives you an idea of that conservative treatment. This is a double major, looking at that double major curve with the Cobb angle. So the goals of surgery, just realize if surgery is the treatment chosen, it is going to drastically affect that person's life for the rest of their life. So if they take surgery, it is because the scoliosis is causing enough problems that they're ready to face the other consequences of the surgery. So you can see here, obviously this is going to be a very invasive surgery, possible implications into the spinal cord. Here are some risks and benefits. Obviously, these risks: elimination or reduction of pain, right? Halting the curve progression, decreasing the deformation, and reduction in the degree curvature. And here are some of the risks, though. Loss of feeling, right? We're going in right there by the spinal cord. Loss of mobility is an obvious must. They're going to go in and fuse those vertebrae together. So the person is going to lose the amount of motion that they have in flexion, extension, rotation, lateral flexion, all types of spinal movements. Paralysis is possible. Again, we're right there by the spinal cord. So these are things just to take into account when thinking about the surgery for the scoliosis. It's likely that someone in class actually knows. It is likely that someone in class actually knows someone that experiences, is probably a better word, experiences scoliosis. And there's actually a graduate student. Maybe I'll ask her if she can come in and display her scoliosis. She has a fairly significant scoliosis. You may actually even know somebody that opted to go for that surgery. So you can see here the drastic reduction in the curve. I want to get to this slide. Look at that scar right there. So you know that this person had had a fixation at least, I don't know, probably that long to get in there. They're going to have to pull all those muscles out of the way, all of our erector spinae, our multifidus, our spinalis muscles. So, okay, so moving, I want to try to cover this next one fairly quickly. Pectus excavatum and pectus carinatum. So what we're looking at here is we're looking at a cave chest, pectus excavatum, or we're looking at a bowed out chest, pectus carinatum. Again, these are going to be extreme examples. There are many examples that are less drastic than these. So what's happening in these? We're experiencing excessive or insufficient growth in that costal cartilage. So it's either going to cause it to buckle in or to buckle out, right? So depending on what that costal cartilage does, the bowing in or the bowing out, is going to be that pectus excavatum or that pectus carinatum. So depending on the severity of the excavatum or the carinatum is going to impact how much it actually affects that person's life. So obviously if you have a pectus excavatum to this extent, you potentially have problems on the heart, you probably have problems on the lungs, and you potentially very easily have some digestive problems on the stomach and the liver, right? So the assessment and the treatment, they can measure the depth of the pectus excavatum. You can see here, this is a non-surgical option with the pressure pump. I want to bring up this individual. I remember watching the Olympics a few years back and actually seeing this individual and going and looking more into them. So this is an individual that experienced pectus excavatum with a sunken-in chest. And when they were young, actually, their doctor told them to take up swimming because they were hoping that as a result of really working out their back muscles, I think it's called, Jace could tell me, I think it's called the breaststroke is the one where you really extend, which I think this individual participated in. So the doctor's idea was that if this person really worked their pecs out a lot, as well as their internal and external obliques, it would help limit the amount of excavatum experienced by this individual. And then, all those years later, here they were in the Olympics. So that's kind of a cool story for that doctor and for that individual. This is a surgical procedure. Again, if it's affecting your heart and your lungs to the point that you're really struggling to function day to day, they have this some surgical procedures where they can come in and implant devices and fixate that costal cartilage for an excavatum to that fixator. So on the carinatum is the exact opposite. So now we're talking about excessive growth, which is causing a buckling out. So treatment of this, especially in a growing individual, they can use some conservative. So we saw that surgical, the negative pressure pump. This time they're going to use something that's going to help push that chest in. And then obviously they can go in and break apart that costal cartilage and cut some out and then hope for reformation going down. So on that costal cartilage, realize it's going to likely occur during the growing years. So starts just before puberty when they really start to grow. You're going to notice that chest. And here's some of the surgical procedures that you can see. So this is after that Nuss procedure. And then on the carinatum, you can see that they went in and trimmed out some of that costal cartilage, limiting the amount that it's going to stick out. And I think that was what I wanted to cover. Dr. Johnson just had this slide. I'll mention it in just a couple seconds here. So that pectus carinatum is not to be confused with the barrel chest here. So a barrel chest can happen in someone that's older where they experience osteoarthritis. Remember that osteoarthritis is going to cause some inflammation and some expansion of the joints. And so that may potentially cause this barrel chest, which is going to be different than our pectus carinatum, which we just talked about there. One is resulting from the costal cartilage, the pectus carinatum. This barrel chest is going to be from an osteoarthritis. And that finishes this video covering scoliosis, pectus carinatum, and pectus excavatum.